All right, gang, part 5 of the video series here on the pediatric patients, and we're now talking about the medical emergencies and circulatory emergencies that will happen. And so we talked about the shock states, we talked about the respiratory states last time, and the severity of those two, which is, of course, respiratory distress, respiratory failure. We have the same kind of thing with shock, and we're going to go, which is, again, hyperperfusion. We're not adequately meeting the oxygen and other essential nutrient needs of the body, and it does not allow us to remove the metabolic waste products. Okay, so again, the result is the tissue can get hypoxic and metabolic acidosis, and eventually the cell death will occur with this. Okay, so again, and the problem is that blood vessels constrict so effectively is that once the blood pressure, when you finally lose all your compensatory mechanisms, these kids drop quick, okay, and they go very fast into a cardiac arrest state. Blood pressure is not a good indicator if the patient's in shock or not, okay? It's actually the poorest indicator, and it's why we call that compensated versus decompensated shock, is because of that. All right, so all these things can cause a shock state, okay? And we usually lump them into 4 categories. Hypovolemic, which includes your blood loss and your dehydration. Septic or distributive, your allergic reactions, your infection states. Obstructive disease, tension pneumothorax causing a shift. Pericarditis causing it not to pump the way that it's supposed to. Okay, and then the last one is a cardiogenic shock where the pump is actually failing, which it very rarely happens, but it does happen. There are kids that are born with congenital heart defects that this can cause a problem with. Okay, so remember, we got to treat shock, and the better we treat shock early. If we don't treat shock early, we're probably going to be dealing with a decompensated patient, and of course that is extremely bad. So it's important to recognize the early signs and symptoms. Tachycardia, poor capillary refill, poor pulse qualities, skin turgor, all of these things, much more reliant than that blood pressure. The blood pressure basically tells us, oh yeah, they're dying now, okay? Long and the short, compensated versus decompensated. They compensate early. We want to catch them in the compensated shock stage. Their blood pressure is still normal, okay? They're going to be tachycardic, tachypnic, okay? And that's going to be the hardest part in PALS, is determining whether the tachycardia and tachypnea is caused by a respiratory or a shock. We find this out via history and physical findings, okay? If I'm listening to a lung and I'm hearing wheezing, yeah, more than likely it's a respiratory cause. If I pinch up their little skin and their capillary refill is 9 seconds, more than likely, and again, I don't have a respiratory component involved, more than likely, yeah, this is a cardiogenic shock problem. Oh yeah, he's had diarrhea for the last 3 days. Ding, ding, ding. We found it out. But we've got to ask those questions of the caregivers in order to find that out for sure. Okay, so again, compensated shock, blood pressure still normal. By the way we tell that, the lower end of the blood pressure, take 70 and add their age, and then 70 plus their age, all right, is the minimum systolic blood pressure. Take their age, double it. Take their age and double it, and then add 70. That should be the lower end of their systolic blood pressure. So for a 5-year-old, double the age, 10, add 70. So their lowest systolic blood pressure that they should have is an 80, okay? But look for these other signs. Decrease urine output. Again, is trying to hold on to fluid. Again, correct the underlying problems. And again, administer high flow O2. Get your venous access. Just understand that venous access, especially in a hypovolemic or distributive state, is going to be a little bit difficult. Matter of fact, in your hypovolemic states, you're probably going to have to be thinking IO at that point, okay? So decompensated, it's no longer, you get the fall in the blood pressure, and again, if you've got the fall in the blood pressure, this patient's about to die on you. You need to start working quickly, okay? Again, blood pressure's gone. We've lost most of our pulses. Again, a significant loss to cardiac output. Okay, they're going to be probably in a lethargy or coma state. They're going to have marked tachycardia, or they've already gone over the scale, and now they're bradycardic, all right? Marked capillary refill, and then cool, pale, dusky, mottled extremities, okay? Again, signs of really late shock. Again, BVM, 100% O2. If they do not have tears or they're not making urine, they're probably dehydrated. Keep thinking upon that line, okay? So irreversible shock, at that point, we can't really do anything for them. And the patient will succumb to organ failure because of it, okay? So getting these kids' kidneys back to working is probably one of the bigger things about our resuscitative techniques with these kids. Cardiogenic shock is when the heart is not maintaining adequate output, okay? In an adult, we can sort of kind of do things to help this, and we can do it with kids as well. Just understand that giving a lot of fluid to a cardiogenic shock patient is going to make them worse quick. And a lot of times, there's one specific case in PALS I know of, where if you give these kids a fluid challenge, you're probably going to end up killing them, okay? They're going to go from really rails to really wet rails, and then, again, because you are now overloading the system. What we really need to do is have that heart beat stronger. Epi-drip is usually our number one thing. Remember, dopamine's kind of wonderful and nice, but we can use the epinephrine on the kids. They don't have the underlying cardiac disease usually, okay? Again, non-cardiogenic shocks, by the way, it does happen. So these are all of our, I talked about these a little bit earlier, distributive or septic shocks. And again, septic shock, we want to give them a norepinephrine, some sort of alpha response in order to cause, and epinephrine works just as well, by the way, on these guys. Norepi for septic shock is probably going to be the biggest one that you want to do. But again, fever, irritability, ill appearance, vomiting, diarrhea, again, rashes that they're not supposed to be having, okay? These are all good signs of a septic shock case, okay? Again, ventilate the patient, oxygenate appropriately, get your IV access, and consider that pressor like epinephrine or norepinephrine is an even better pressor, okay? Norepinephrine in a very low dose because, again, we're talking about little kids, okay? Again, anaphylactic shock, again, give them some sort of antihistamine. Epinephrine works really good. Bronchodilator works very good for these kids. But give it IM, get it in them quick. If you can, give it IV, okay? Decompensated shock, again, you're going to need to give 1 to 10,000 epi boluses, okay? If they are to that point where they're about to arrest, a push dose of epi is a good thing to do with a pediatric patient, all right? Kids don't have the underlying heart conditions that the adults do, so keep that in mind, all right? Now, your neurogenic shocks, again, these are when you got a spinal cord break. Pressor agents work really good here as well, okay? Your norepinephrine, epinephrine are what would help that. Again, cardiogenic shock, kind of rare, but again, you do have it. The big drug for cardiogenic shock in the pediatric patient, by the way, is Milrinone. But Milrinone, again, most of us don't carry. So next closest sort of substitution, epinephrine or dopamine, okay? And again, it's usually due to a defect at birth. Usually the cyanotic spells. There's a high oxygen demand. Oxygenate them appropriately. Usually you get them past a congenital heart defect issue. If they do have tetralogy de Fallot, having them sit down like they're in a catcher's position, knees up to the clavicles, that actually helps out quite a bit, okay? But again, cardiomyopathies, by the way, disease or dysfunction of the cardiac muscle itself. This is when they're going to have the fatigue, the crackles, jugular vein distension. Their liver is going to be huge. Again, they're going to have a lot of peripheral edema, looking like a CHF patient, kind of. And essentially, it is, really. But again, supplement, restrict the fluids, get your IV, and take them where they can actually work on sick kids, all right? Arrhythmias, very rare in children, but they can cause pump failure, which can lead to cardiogenic shock. And again, we treat the specific arrhythmia in question. If they have a bunch of PVCs, usually your amiodarone or lidocaine is your best bet. SVTs, again, adenosine, 0.1 milligrams per kilogram. and that's for your tachyarrhythmias. But remember, for supraventricular tachycardia in kids, it's above 220 beats a minute, okay? With adults, we say 150. With kids, 220, okay? Supraventricular tachycardias. Again, vagal maneuvers usually work really good. How do I do a vagal maneuver on a kid? Ice quickly to the face, having them blow through the syringe if they're old enough to do so. Again, those are the only ones that we usually use. The ice to the face we usually use on the kids. And if they're showing signs of decompensation, we would do synchronized cardioversion. Yeah, good luck. I can tell you, I think I've had one case in 30 years where I actually had to consider it, and then I ended up giving them a dentist, and then it worked just like that. VTAC or VFib, again, they usually are unable to tolerate the arrhythmia. They'll start to develop signs of shock, and these guys, of course, again, we treat it with our ACLS algorithm, basically the same thing. Only thing that really changes is your dosing and your electrical therapies on that, okay? Bradyarrhythmias, bag them, some more, bag, ventilate. Again, usually a slow, narrow, complex rhythm, or again, speed up the heart rate. Epinephrine is our way to go here, okay? Ventilate them first. If that doesn't work, go to epinephrine. We usually do not pace children, okay? It's a very rare, matter of fact, I remember going up to the PICU and go, hey, what do you guys start pacing at? And they go, we don't use a pacer, we use epi. Oh, okay, perfect. All right. The pulseless arrest, usually it's due to asystole or PEA. Again, remember your epinephrine doses on these guys, find the underlying cause, all right? Again, make sure you got your CPR going and continue that simple thing. Same thing with VFib or pulseless VTAC. Again, it's very uncommon in children, and it's usually because they've electrocuted themselves, okay? They're usually pulseless and apneic. Again, ACLS algorithms work really good here. Just remember, change your medication dosing on these guys. So again, it's defibrillate, epi, defibrillate, amio, defibrillate, epi again, defibrillate, amio the second dose, okay? And then epi the third time, and then amiodarone the third time, and then let's do something else, okay? Don't forget to rule out your H's and T's while you're doing that. PEA, again, find out the cause. 99% of the time, it's usually having to do with hypoxia, okay? Neurogenic emergencies, okay? Seizures, pediatric seizures. Number one cause is because of a quick change in body temperature, aka spiking of fever, okay? By the way to send them into another seizure is to rapidly cool them down in a non-controlled setting. In other words, dunk them in a ice bath. Yep, you're probably going to cause another seizure, okay? So, hypoxia is another one. Infections, again, if they are early stage epileptic, they don't know the cause of that. Electrolyte disturbances, all of these things can cause a seizure. But the big ones is probably these two in the middle, fever, hypoxia, and I'd say infections is probably the third one, okay? So again, they can have head trauma. If their blood sugar is low, it can also cause it. Toxins or tumors, or they have malformations, okay? All of these things can cause a seizure, okay? Again, partial seizures or focal motors, and then these guys can do the eye blinking, lip smacking. There really is no loss of consciousness. They just kind of check out. Generalized seizures is when you have the tonic-clonic movements. They do lose consciousness during that. Usually they become incontinent of urine most of the time with these guys. Status epilepticus, though, these are the guys that continued prolonged periods of apnea. Make sure that we ventilate these patients, and usually this is a Valium. You can try the Versed, but usually I found Valium works a little bit better on the status epilepticus. Febrile seizures, it's usually due to the change in temperature. Again, Valium or Versed work really good on these. But again, don't dunk them in ice water. Don't bathe them down in ice. Don't put them in cold water. Again, it's the sudden change in temperature that's causing the seizure activities, okay? If a kid has a seizure, we take them to the hospital, period. Okay? Determine the history of the seizures. We want to make sure that it is not one of the more dangerous ones versus it's just the fever. Good news is most of them is just a little usually fever or dehydration, But guys, we can't be sure of that in the field. And with that saying, we got to make sure that we transport these patients. If they are having a seizure, you need to place on the floor or on a bed and lay them on their side, away from furniture. Again, let them have the seizure. We can start doing things. Don't force anything between their teeth. Believe me, when they run out of fuel, they'll stop seizing. Okay. Again, that's when we step in. Make sure we got to make sure we're bagging these kids, because that's the disordered control of breathing. And again, that's what we're most worried about, keeping that heart rate up. Okay. So ventilate, 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 ventilate. Okay. And if febrile, again, remove the excess clothing, allow them to cool off naturally. Don't dunk them in an ice bath. Okay. So again, status epilepticus, again, IV, get the IV started, diazepam or lorazepam. Think rectal Valium or rectal Versed in these cases, or IM. Okay. Now just remember that if you give too much, you got to watch out for respiratory depression. Okay. And I'm not going to say that I've definitely done it. I stopped. The good news is I stopped the seizure. The bad news is I stopped the breathing effort. Okay. Yes, it has happened. Okay. And sometimes you have to do that in order to get the seizure to stop. All right. And then they may actually, the docs, I know that in Levy County we used to give acetaminophen or Motrin to the children with the fever. We would do that actually to start the fever lowering process. But again, we had an hour transport time. But usually by the time we got to the hospital, the fever was already starting to come down. Meningitis is an infection of the lining of the brains. It can be bacterial or viral. Bacterial, very highly transmittable, very highly contagious. So make sure that you got your mask on if this is the case. Again, usually nausea and vomiting, it's a sign of something worse, and it's usually gastroenteritis that's usually causing it, or some sort of food poisoning. The problem is it can dehydrate them very quickly. So your IV fluids, it may be indicated. If they've been vomiting a whole bunch, they may require 2 or 3 fluid boluses to return them back. Diarrhea is considered 10 or more stools a day, and again, the biggest thing is they dehydrate very quickly, and they can cause significant life-threatening diarrhea, so you might have to give more than one fluid challenge in order to get these guys back out of the trouble zone. Kids do not have the sugar stores, okay? Glucagon, especially the younger they are, less effective, okay? So again, blood sugar. Diabetic children are at increased risk of this because, again, by the way, good news is most diabetic kids nowadays are not being put on shots. They're being put on insulin pumps with continuous glucose monitoring. That's the good news. The bad news is that we still got kids out there on shots. So again, make sure you get their blood sugar. Again, treat with D25 if they're under the age of 1. Matter of fact, I'm more of a fan of D10. Okay, it works better. It's less caustic to their little veins. Okay. Good news is these kids that are diabetic usually know. Make sure that you carry extra snacks. They can lose their sugar if they are burning up a lot of activity. Okay. Make sure that they're eating regularly, and again, make sure that they're monitoring their blood sugars. Okay. Eat extra snacks, especially if they're doing. If they're going to bed, they should be above 120 before they go to bed, and replace the carbohydrates in the meal plan. So one of the things I'll also tell you with this is that at bedtime, just remember, at the start of their sleep, they're not going to burn up as much fuel. The problem is around the 3 o'clock hour is when they start really burning up, because your body's in that repair mode while they're sleeping. So they're going to burn up a ton of sugar. So yes, going to a diabetic, especially a kid that drops below 70, that's kind of normal for those kids to do that. Okay, so that's why we try to teach the parents, hey, get the sugar up 120, 130 before we go to bed. Okay, and then if they find out how much insulin has been given and when it was given, because remember, we talked about insulin administration. Certain insulins peak at different times, okay? So, and we'll talk about a lot more about that when we get to endocrinology and we start talking about the diabetic patient. Again, make sure you got all your stuff for this. Again, consult medical direction for dextrose or IM glucagon. Guys, again, the younger the kid is, the glucagon, you're kind of squeezing a stone for water. You don't have the glucagon stores in order to break that down. Okay, so the dextrose again, 10% dextrose is just fine. 1 to 8 D25 is just fine to give them. Just make sure you're giving them the right amount per the Broslow tape. Okay, you might gonna have to do a little bit of math there. Okay, high blood sugar. If they have high blood sugar, again, type 1 diabetics, they're going to get that fruity smell. Usually they will deteriorate to coma. Again, usually they've eaten too much food relative to their insulin, or they've missed insulin, or they get ill or stressed. Their sugar goes through the roof. And again, they get a lot of fluid loss because the body starts to pee all of that extra glucose out. And so again, make sure you monitor your vital signs. You may actually have to give fluid boluses to replace. And again, they're going to get that fruity ketone acetone breath. Ugh, yeah, yuck. Again, give them fluid boluses, and again, they're probably going to start peeing on you, by the way. Okay, and actually, that's kind of a good thing. We want to get all that urine, we want to get all that extra sugar that's in the kidneys out. Okay, so again, monitor their status. Be prepared to intubate if they do go into a coma state. If they did take toxic exposures, again, and that's one of the biggest problems is let's find out exactly what it is that caused the problem. We got to find the agent. Remember when I said they ate a bunch of Flintstones with gummies earlier? That's why. Most of those guys contain iron, which can lead to poisoning as well. So find out what it is. Make sure that, teach safety in the home. Put the meds away where the kids can't get them. Make sure that they don't leave the amphetamines out. All right, don't leave the meth out. Because again, in a low-income house, that might be one of the things we got to make sure that they understand. Again, aspirin and acetaminophen, we see mom and dad take it all the time, so we're going to just down the bottle. Okay, and I will tell you, I have seen a girl die from acetaminophen overdose. It is not the thing. It's one of the things I can tell you right now that kind of haunts me till to this day. Extremely painful, really bad. So find out the agent in which they did have, and then again, poison control is your friend, and listen to them. Okay, they can tell you what exactly it is that you need to do. Guys, there is nobody here that's got enough experience that they can do contact poison control, find out what the antidote is, and have them give you recommendations. It is in every protocol that I've ever seen, and it should be what you should be doing. Unresponsive poison patient, again, secure the airway, rule out trauma as a cause for the altered mental status, and find out what it is they took. All right, I know that one was kind of long, I know, but we're done with the medical parts, and we got the trauma left to go. So we'll get this one on the next video, and I'll see y'all then.